Okay, so what about the femoral nerve? Well, let's review the anatomy of the femoral nerve. The femoral nerve is formed from the posterior divisions. The posterior divisions of L2, L3, and L4. We said that the lateral femorocutaneous nerve was also formed from posterior divisions of L2 and L3. So the femoral nerve has a similar derivation, comes from posterior divisions of L2 and L3, and also now with a large contribution from L4, and we talked about the L4 patellar reflex. Okay, so the femoral nerve is the largest branch of the lumbar plexus. Comes from the posterior divisions of L2, L3, and L4. And like the lateral femorocutaneous nerve, it descends down through the fibers of the psoas major, emerging from the psoas at the lower part of its lateral border. So a little bit lower than the lateral femorocutaneous nerve. And it passes down between the psoas and the iliacus muscle, travels down behind the iliac fascia, and then runs beneath the inguinal ligament into the thigh. And once it's in the thigh, it spreads from there into an anterior and a posterior division. And are you starting to get a feel of a common theme of nerve roots to nerves? They split, and they split, and they split, and they split, and ultimately they end up in what we call terminal branches. So the femoral nerve, when it passes underneath the inguinal ligament, splits into an anterior and a posterior division. Now, before it does so, within the abdomen, the femoral nerve gives off small branches to the iliacus muscle, and a branch which is distributed upon the upper part of the femoral artery, which then continues downward. And then in the thigh, the anterior division of the femoral nerve gives off anterior cutaneous and muscular branches. So it's kind of interesting that the femoral nerve gives off small branches to the iliacus muscle. Now recall that the iliacus combines with the psoas to form the iliopsoas, and the psoas gets its motor nerve supply from L2 and L3 prior to the point at which L2 and L3 combine with L4 to give us the femoral nerve. So only the iliacus gets its nerve supply per se from the femoral nerve, and we'll talk about how to differentiate between an L2, L3 lesion and a femoral nerve lesion, and how that affects the psoas and the iliacus. So now we're down in the thigh, and in the thigh, the anterior division of the femoral nerve gives off cutaneous and muscular branches. Now, with regards to the cutaneous branches, the anterior cutaneous branches comprise the following nerves. It comprises both the intermediate femorocutaneous nerve and also the medial femorocutaneous nerve. Now, the AMA guides don't describe those two contributions. The AMA guides simply group these two branches into a distribution that they call the anterior cutaneous nerve. So just remember that when you're looking at figure 17.8 in the AMA guides, where it shows what they call the femoral anterior cutaneous nerve, that is actually the distribution of two smaller cutaneous nerves. the intermediate cutaneous nerve and the medial cutaneous nerve. And remember that the lateral cutaneous nerve, meaning the lateral femoral cutaneous nerve, is not a branch of the femoral nerve. It's a branch from the lumbar plexus, L2 and L3. So really covering the anterolateral portion of the thigh, and all but the most tiniest strip down the back of the thigh is covered by the lateral femoral cutaneous nerve, and then what the AMA guides call the anterior cutaneous nerve, which travels in the femoral nerve. Now the muscular branches, also known as the rami muscularis, gives rise to several branches. The nerve to the pectineus muscle arises immediately below the inguinal ligament and passes behind the femoral sheath to enter the anterior surface of the pectineus muscle. Then the nerve to the sartorius arises in common with the intermediate cutaneous nerve. From there, we have the posterior division, and the posterior division gives off muscular branches that supply the four parts of the quadriceps. The branch to the rectus femoris enters the upper part of the deep surface of the rectus femoris muscle. It enters the upper part of the deep surface. So you can imagine that at that point the femoral nerve is quite deep, traveling just in front of the femur. From here it also sends out an articular branch to the hip joint. And as you think about that, what would be the function of the articular branch to the hip joint? What would be the function of the articular branch to the hip joint? Well, that is a sensory fiber that brings proprioceptive and mechanoreceptive information from the joint up into the spinal cord. Information about joint position, joint tension, joint pain would be carried in the articular branch. And this is consistent with Hilton's law. And if you recall from neuroanatomy or neurophysiology class many years ago, you recall that Hilton's law states that innervation to joints, in this case we're talking about the hip joint, innervations to joints comes from the same nerves that innervate the muscles that move the joint. So the rectus femoris muscle is a hip flexor muscle. It's one of the hip flexor muscles. It's also a knee extensor, but one of its functions is a hip flexor. And this is consistent with Hilton's law because the rectus femoris provides for movement at the hip joint, and it also supplies an articular branch to the hip joint. The nerve to the vastus lateralis also supplies an articular branch to the knee joint. The nerve to the vastus medialis also supplies an articular branch to the knee joint. And then with regards to the vastus intermedius, there are 2 to 3 nerves that supply motor function to the vastus intermedius, and they enter the anterior surface of the muscle about the middle of the thigh. The anterior surface of the muscle about the middle of the thigh, and a filament from one of these descends through the muscle to the articularis genu, and then also from there travels on down and sends an articular branch to the knee joint. So the femoral nerve, let's talk about the muscles and muscle actions that are controlled by the femoral nerve. The femoral nerve supplies the motor supply to the iliacus muscle, and the iliacus muscle is a hip flexor. So the iliacus is responsible for flexion of the femur upon the pelvis, hip joint flexion. The femoral nerve sends a branch also to the sartorius muscle. Sartorius muscle produces kind of a strange movement. It's kind of a combined movement at the hip, combined movement of hip flexion, combined movement of hip initially adduction and then hip abduction, and then also lateral rotation of the hip. And you can think of the function of the sartorius muscle as the muscle responsible for allowing you to take a look at the bottom of your foot. If you were to get a piece of gum stuck on your shoe or something like that and you wanted to look on the bottom of your foot, it's the sartorius muscle that would do that sort of combined movement of flexing the hip, abducting, and laterally rotating the hip. The sartorius also is a weak knee flexor because it does cross down the knee and attach onto the pes anserine in combination with the gracilis and the semitendinosus muscles. So a couple of functions of the sartorius muscle, some of which are weak. It's a weak knee flexor and it's a weak hip abductor, but nonetheless does contribute to those motions. And then finally, the femoral nerve innervates all four of the quadricep muscles. Those, of course, provide for knee extension, and it's the knee extension function of the femoral nerve that gives us its most reliable and its most direct effect, especially that we can test in our physical examination procedures. The sensory supply from the femoral nerve is twofold, really. The AMA guides describe the anterior cutaneous nerve. Other references refer to those as the medial and intermediate cutaneous nerves, but the AMA guides group them into one nerve or one distribution that they call the anterior cutaneous nerve. This supplies sensation to the anterior upper thigh to include the top of the knee. So think about that, and you might just rub that section of your thigh, the anterior upper thigh, to include the top of the knee. And the lateral part of the upper thigh, that would be the lateral femoral cutaneous nerve. Okay, the anterior thigh is the anterior cutaneous nerve. So I'm sort of setting the stage here for you for what's to come. If we have a lateral cutaneous nerve and we have an anterior cutaneous nerve, is it possible that we could also have a posterior cutaneous nerve? And we're going to talk about the posterior cutaneous nerve here in a couple minutes. Also, the anterior cutaneous nerve communicates with the infrapatellar branch of the saphenous to form the patellar plexus. Now, the saphenous is the continuation of the femoral nerve below the knee. And that is, after the femoral nerve gives off all of its motor branches, finally to all of the quadricep muscles, the femoral nerve continues on as a sensory nerve, known as the saphenous nerve. And the saphenous nerve is largely L3 and L4 contributions. By now, what was left of L2 has all but disappeared, and there is no more L2 contribution left to the saphenous nerve. And the saphenous nerve provides for sensation to the anterior medial lower leg. The anterior medial lower leg, from the crest of the tibia medialward. It also provides for a small strip of sensation in the posterior medial leg, from the division between the two heads of the gastrocnemius muscle medialward. So I would kind of describe that as like 25 to 50% of the circumference of the lower leg, mostly the medial portion, actually all medial portion, is covered by the saphenous nerve. 25 to 50%, maybe even as much as 50%, since we're considering that the saphenous nerve distribution continues posteriorward about to the division between the two heads of the gastrocnemius muscle. Well, that's directly down the midline of the posterior aspect of the lower leg. So if you then continue from there around medialward to the tibial crest, that's about 50% of the circumference of the lower leg. So the femoral nerve gives us a lot of functions, sensory and motor functions. So where are some of the potential sites of injury of the femoral nerve? Well, a couple of main locations where the femoral nerve can be injured. Can be injured in the pelvis and can be injured outside the pelvis as it passes underneath the inguinal ligament. Now in the pelvis, injuries, open injuries such as from gunshots, such as from knife wounds, such as from needle puncture, such as from contusion or compression or crush injury. The femoral nerve can be injured in the pelvic region, where it comes out between the psoas and the iliacus muscle, or in the case of an abdominal crush injury, sufficient to compress the nerve behind the psoas major, can be injured in that region. So general injuries to the pelvis can injure the femoral nerve either up very high, close to the spine, where the L2, L3, and L4 nerve roots conjoin to form the femoral nerve, or at any point thereafter as the nerve passes out from behind the psoas to eventually come underneath the inguinal ligament. Now below the inguinal ligament, any pathology to the hip joint can cause injury to the femoral nerve. And so what kind of injury could you have to the hip joint? How about osteoarthritis of the hip joint? How about injury to the hip joint? How about an anterior dislocation of the hip joint? How about surgical procedures that involve hip replacement? How about strain, stretch, or tear, injury, or abscess of the psoas tendon, or injury to the tendon of the vastus intermedius, or any of the structures that approach the capsule and the femoral head and the acetabulum can cause injury to the femoral nerve in that region. And in this region by the hip joint, by now, the branches to the iliacus have already come off the nerve to provide for motor innervation to the iliacus, because obviously the hip joint is below the iliac crest. So any injury in this region would have preserved function of the iliacus. Now, because the iliacus is a hip flexor, and we're talking about pathology to the hip joint, it may be difficult to discern between any exam finding of weakness, it might be difficult to discern whether that's due to pathology with the hip joint, or pathology with the iliacus, or even pathology at all with the femoral nerve. That's where clinical diagnostic skills come in, is to differentiate between those potential causes, and it may not be something that can be done by physical exam. Also below the inguinal ligament, any position that involves prolonged hip flexion, especially with hip abduction and external rotation, can compress the femoral nerve beneath the inguinal ligament. Any position that involves acute hyperextension of the thigh, and you may recall by physical exam there's even an examination maneuver that involves hyperextension of the thigh. It goes by various names, but in this context it's known as the femoral nerve stretch test. So the femoral nerve generally, at least in the workers' compensation setting, there's two main locations where that nerve can become injured. Can become injured inside the pelvis, or as it passes beneath the inguinal ligament. Now with an intrapelvic lesion, we're going to have both sensory and motor findings. With regards to sensory, we're going to have decreased light touch, maybe some numbness, maybe some tingling in the anterior thigh. This is going to include the kneecap. Sensory loss may occur along the medial aspect of the leg in the distribution of the saphenous nerve. And we said that that's about 50% of the circumference of the lower leg. With motor findings, we're going to see decreased strength of hip flexion. And depending upon where the lesion is, we may see involvement of the psoas muscle, we may see involvement of the iliacus muscle, we may see involvement of both the psoas and the iliacus, because high lesions of the femoral nerve are going to affect the nerve, particularly the nerve roots, the L2 and L3 nerve roots. They're going to affect those nerve roots prior to the point at which the motor branches come off to either the psoas or the iliacus. Now the femoral nerve does not actually form until below the motor branches to the psoas muscles. So with a lesion of the femoral nerve, right at the point at which the L4 nerve root combines with L2 and L3, we're going to see the function of the psoas preserved, whereas the function of the iliacus may be compromised. We may also see decreased strength of knee extension. Probably wouldn't be able to find any finding for the sartorius muscle. And interesting that both hip flexion through the psoas and iliacus and knee extension through the quadriceps would both be affected, because high lesions affect both the hip flexors and the knee extensors. High lesions meaning lesions, intrapelvic lesions, intra-abdominal injury to the femoral nerve. Now in the case of injury to the femoral nerve at the inguinal ligament, we're going to see that hip flexion strength is preserved, because by the time the femoral nerve gets to the inguinal ligament, it's already given off its branches to the iliacus and to the psoas. So low lesion does not affect the branch to the iliacus, and the branches to the psoas are from the L2 and L3 nerve roots prior to the formation of the femoral nerve. So those are some of the physical examination findings with femoral nerve lesions.